Good morning. I'm glad you're here. I met a lot of you yesterday, and for those of you that I haven't met today, we hope to have a fantastic microlab day and a number of other presentations that I'm looking forward to, and I think you should too. I want to talk to you a little bit about what this concept of a microlab means to us and what it inspires us, and really echo some of the things that I heard yesterday. We did hear a lot about this local notion, but there's one comment that one of the presenters gave, which is the notion of if I'm a healthcare worker, and how not to be just a passive part of that equation, how to be an active part of the equation in technology. And what I hope is to show you some examples of what that's like in action. And so yesterday we saw 2 tons of medical waste. For those of you who didn't see this is basically the result of good intentions when we donate medical technology and how we have to respond. And one of the things that we do a lot is how do we go around hospitals and hanging out with clinics and nurses and healthcare workers, and how do we find and uncover those everyday little hacks that they'll do in the clinic. They may not be telling everybody, but they save lives. And we see this not just in medicine. This is a picture taken in Syria. And as horrible as that conflict is, regardless of which side you're on, what it shows us is that ingenuity cuts across all sorts of domains, regardless of the numbers of resources you may have. And I find these pictures really compelling because what it tells us is that if we can really mine the ingenuity of people who were never born into an engineering school program or academic program, and then channel that so that they can do other things like this, I think that there's a tremendous world of possibilities. So think about when you go back to these countries and what these people are working on, and how do we make sure that they don't continue to just do this while in conflict. Because what we find when we go around the world is that lots of people around the world are inventing lots of little things with us when we leave, and certainly long after we're gone, and continue their own. DIY medical technology is one of those things that as a first instant, people think this is not something you should try at home. But what we have is a tremendous history of it. This is a man in China who, after 6 years on dialysis, got fed up. Well, actually, didn't even get into 6 years. He got prescribed dialysis. He couldn't afford it. And he made his own dialysis machine from parts that he ordered online and things that he assembled at home, and has done it for 6 years. And you could Google it. It's really compelling. And we look at this, we say, I'm sure all the buzzwords that I generally try to look up in public health is like, oh my gosh, standard of care, evaluation, outcomes, like it just, every single alarm that a policy administrator would run away from gets fired up when we see something like this. But we've seen this picture before. So maybe you should try this at home. So this is the assistant of Dr. Andreas Grunzig in Switzerland. And in 1977, he made the first angioplasty balloon catheterization procedure, and then went on to become, I don't think it was a chair, but certainly one of the top people at Emory University's angioplasty program, which is one of the top in the world now. And he basically invented the concept. He didn't have a lab either. He was in Zurich, and this is his apartment, roughly between 11 and 3 a.m. in the morning, where he would come after work and get his assistant, his next-door neighbor, to basically create catheters on the kitchen counter. And after doing that, he revolutionized an entire industry. And this is not in Uganda or in Honduras. This is in Switzerland. Before him, Charles Dotter also invented a number of different interventional radiology tools. And he was using guitar strings and VW cables to fashion the different shapes that needed to go inside his body. These are fairly invasive and extreme examples. But Dr. Dotter teamed up with somebody else and went on to found Cook Medical, a large medical device company today. And this, of course, is Earl Bakken, who in the 1950s was approached by a doctor who had patients with cardiac trouble and made a pacemaker in his garage. That's him. And then 30 days later was inside another patient, and then went on to found Medtronic, which is one of the giants in the industry. And so this requires us to take a delicate departure away from what are traditional notions of the pipeline of innovation that stems from either ivory tower and then all the way out through industry, and requires us to understand that these people started they're not a whole lot different, maybe geography, from those other people that you saw earlier in China and Syria and Libya, and the ones that we find every day in the developing world, whether it's in a hospital setting, or a hospital setting here, or even interventions on a daily community health level. It's one of those things that we often think this is what we need to make these types of innovations. And I find that that's not true. This is a picture of diagnostics hanging from a string, drying out. And this is actually not Syria or Libya. This is 77 Massachusetts Avenue. It's a loading dock at MIT. And this was one of our first laboratories. And as you can tell, we had to share it with like corn shellers and charcoal and barbituric acid that we were drying to make arterial strips so that we could test tuberculosis patients in Pakistan. Unlike North Carolina or other places, Cambridge doesn't have a lot of space. So we are thankful for what we got. We have grown now, but when we started to do this, we realized if we can build diagnostics here, we could probably build them anywhere. And that's what we started to think about. And we started to go into this notion of construction sets to empower, these are basically mobile microlabs, to empower people to do what we were doing at MIT. And I'm sure when we landed in Nicaragua, people thought, oh yeah, I'm sure they have like a robot assisting them and everything. And no, I mean, we were parking bicycles, and that's Amy Smith's rope thingies. And it was not ideal, but we made it work. And then we grew this notion and this talent for making pop-up labs inside hotel rooms around the world. It really scares the staff, but it works. And so how do we do this? Structurally, systematically. One of the things that we found is that for us, the drivers of the next instruction set are, in fact, the DIY revolution. How do we get those people who are building everyday devices around North Carolina, around this area, around the world, and drive them towards health? Because until now, they've been told, you'll shoot your eye out. Don't touch, you can build little blenders that tweet, but do not touch health. And I think that's a mistake. I think we should open our arms to and welcome these individuals. That's certainly what we're doing. We see a lot of maker spaces. We heard Eric Hersman talk yesterday, and a number of other people. And our maker spaces are on the rise. And one of the notions that I find really interesting is the concept of institutional maker spaces. The fact that we're not just seeing them in neighborhoods and community settings, we're actually seeing them within institutions. NASA, who you might guess has 1 million labs or something, actually has a makerspace in Houston. The Army has a forward deployed makerspace in Afghanistan. And we're now working domestically, actually, after working many years in Central America, on deploying makerspaces in hospitals to accelerate that convergence of fabrication and inventiveness. The other driver, I think, is what I call supply chain arbitrage, the ability to hack one thing, to know which supply chains are more efficient than others, and then reinvent those products based on what we have locally. So medical devices have a very inefficient supply chain. So if you think about it, it's probably easier for you to find a handheld console, like a Sega, like a Game Boy in my time, or whatever, the PS2, in southern Vietnam, than to find a glucometer. And if you really crunch numbers, they have generally the same amount of complexity. But one is riding on really fast rails of supply chains, and one of them just doesn't. It's very expensive. So what we do is we hack it, and when we look at a toy, we say, that's interesting, but we've trained ourselves to think, this is what it looks like on the inside. What can we harvest from these parts? How can we reinvent them? How can we use them for something else? Personal fabrication, digital fabrication tools. I think a lot of you have heard the buzz about 3D printing and personal fabrication. There's beyond 3D printing, but it is becoming a lot more affordable, and I think we'll see a lot more of that. And then finally, kits. The first steam engine was not sold as a product. It was sold as a kit that you would buy, because they knew that you had to get the parts and then customize them and personalize them to your own mill. And we've seen a number of these innovations, of these approaches of the form factors with kits. The first Apple computer was a kit. You see kits when you go to the bicycle store, when you buy plumbing supplies at Home Depot. It just lowers that prototyping barrier from having to work with nothing and build an expertise to work with something. And we're doing that in healthcare. As I mentioned, aimed at people like Daniela, who was hacking her stethoscope to make it work. And that's when we made the medikits and we'd make construction sets for health. And I'm going to go a little bit into what it means, but these are basically plug-and-play parts that you can use to make medical devices. So in this case, everybody knows what a nebulizer is, I think, or you'll learn this afternoon if you come to our micro lab. This is about a $70 device. It uses electricity, and most of the time when I go to the developing world, they say it's broken, and they point to the big blue thing. And what we've shown them is that it's really not about just a big blue thing. We can hack local supply chains. We can use different components. And using a medikit-like approach, we can then make a nebulizer that's about $7. You can use basically a bicycle pump, and the magic happens actually in the nebulization cup. And we've deployed them around the world, and people are using them. And we did test them with fancy lasers and machines at MIT, and these convergent lines show us that we basically get the same output from one of these devices as one of the industrial devices. You just have to human power it, which is locally available. And these are nurses showing doctors how to assemble them, and they've never even heard of the word prototyping or the word design, but they jump right into it because what they call workarounds, we call inventions. And what a lot of people might call positive deviance, which I don't think is a good word to use for this sort of thing, I think is just, their own innate creativity in action. And then they can do other things like adapt them for pediatric uses and make other, and power two nebulizers for when you might only have one power source, for instance. And the architecture, basically, when you're designing a kit, you want to start with core blocks. You add modifiers so that you can add a little bit of modifications. You want to make sure that you're always also using local materials. It's going to be a hybrid, and then we think that's going to move in some action. And underlying that, what we do is we add a language of design. What I mean by that is everybody here probably knows what a 2x3 Lego brick looks like. If you think about it for 10 seconds, you have an image in your head. And the reason is that Lego has embedded a language of design in that. How do we do that for other healthcare devices so we don't have to do a 3-page write-up of what 2x3 Lego block is? And that means that then we start communicating based on the hardware, not just on the instructions. You want to constrain the degrees of freedom. So that's why Lego doesn't just ship you a blob of plastic that you later mold. It ships you certain parts that fit in certain ways. And finally, what we think is the best driver of technology adoption, or the best indicator of technology adoption, is when you take your device and then you find out that it's been hacked locally, because that means to take ownership of the design. You no longer dominate by design. So these are some examples. This is standard diagnostics. We made them plug-and-play parts. So if you look at this is an evolution of our designs where we can actually plug and play different blocks and create multiplex diagnostics for paper diagnostics. So somebody in the western part of the country can call somebody else and say, hey, if you put together the Romanian flag, it makes a great combination, syphilis test and glucose, or whatever is useful for you guys. But that's the thing, I don't know, but they know. So why would I just spend thousands of miles and dollars interviewing them to make the ultimate device when I can just give them the tools so that they can make it? This is what they look like now. And so and we went through probably like 16 different prototypes to get to this. This is a microfluidic lab on a chip where we use Lego pieces to run the fluids. And Emma Tall, the student that made these and invented this, is here. So if you want to talk to Emma and Robin, they're here in this thing. And this is the notion of again, hacking these toys and these these supply chains. So this is Claudia on the left making a prototype centrifuge out of a Ferris wheel that she found locally, and then she's going to test it. In the center is an inhaler made out of a toy helicopter. And on the right is a nurse that we then took to the toy store. And if you want to cue the video, we basically went into Nicaragua, into a toy store. Video, please. And basically, this is, you know, you're coming in, you're like, yeah, we're from MIT, let's go to the toy store. And they just don't expect that. Can you hit play, please? And so there we are, they bought a gun, and you know, again, they'd never received design training in their life. And in about an hour and a half, you know, once they took it apart and learned how it works, they made a very, very simple IV alarm, because that's what they needed. And it works, and it's not pretty. Of course, it looks like an IED, but the reality is that, again, they've never received training in their life. So you have to give them credit for, if this is their first try, I think it's an immense first try. And then they go, and then they're not afraid of thinking about new ideas. This is a nurse in Dominican Republic from Concord, Massachusetts, using the Medicus to do microscopy on phones. And if you notice, that's a hacked film cartridge, for those of you who still remember film canisters, as a microscope slide holder. And one of the things that I want to challenge a lot of you, and I know I've talked to Maria and other people here, is that we need better tools to get the word out, not just about these things, but best practices. Don't just put it online. Reality is we know we can get stuff online. And we know we have the wireless accessibility and the 3G and all the awesomeness that digital communications is. But what I find out is that the culture is still not there. And if we just publish it in Nature or in Lancet and the BMJ, they don't read that stuff. So think about new ways in which we can get stuff out, and think about how to affect policy change at the higher level, so that we can get more people involved in this type of work. Because right now I think we have some really misdirected incentives and resources. This is a picture of the Ugandan space program. You guys know more about neonatal mortality in Uganda than I do, but really they should be doing better things in the space program. I'm sorry. They have some issues. We're still sorting them out, clearly. But I would love for those engineers to instead work on the things that actually matter for that country and other countries around them. But we still have hope. This is Dr. Yombo Awajobi, who exemplifies. He's in Nigeria. And we didn't train him. He trains us at MIT. And he's basically, if you look him up, he's designed a number of different innovations in his hospital and sells them to other hospitals around the Arua region in Nigeria. So he hasn't just stepped back and said, let's see what the people wearing the red MIT shirts bring by. If anything, he's the one that mentors our students. And I think there's more people like him around the world, and like our nurses around the world, and they need your support, your validation, and your trust, that even if they do look like IEDs, they one day might save some lives. Thank you.